Good morning. Again, I want to thank Dr. Kanda and the organizing committee for being part of this excellent symposium. I want to talk a little bit about the asymptomatic carotid stenosis and should they be treated. It's a very controversial issue. You know, in the United States, about 80% of the carotids that are operated on for carotid endarterectomy are asymptomatic. In Europe, on the other hand, about 80% of the carotids that are operated on are symptomatic. Only about 20% are asymptomatic. Those are my disclosures. So from a perspective, from a conservative vascular surgeon, that's me, should they be treated, asymptomatic carotid lesions? I think the answer is yes, but the real question, the questions that need to be answered are, what are the indications for treating them, when to treat, treatment method, should it be best medical therapy, endarterectomy, or carotid angioplasty and stent? Unfortunately, the current practice management for carotid stenosis is based on 30-year-old or greater clinical trials. The two were NASET and ACATS. They both are 30 years old. The symptomatic carotid stenosis was 70 to 99%. Randomized trial between 1981 and 1994. The asymptomatic was a 50 to 99% stenosis. Again, a randomized trial between 1983 and 2003. You all are aware of the criticisms of these trials. First of all, the medical management at that time was really inferior. It consisted primarily of aspirin and risk factor modification. There were no statins. There were no other antiplatelet agents. And the drugs used for managing their comorbidities, hypertension, heart disease, a variety of other issues, were really quite poor. The results, however, for symptomatic stenosis was about a 3% per year prevention benefit from undergoing a carotid endarterectomy if you were symptomatic, but you had a 6% stroke and death risk at 30 days. If you were asymptomatic, you had a 0.5 to 1% per year prevention benefit from a CEA, 3% stroke and death risk at 30 days. That's all pretty well documented. Medical management today, and the reason that I think we need to relook at this, is better. We manage their comorbidities better, we manage their risk factors better. There's another interesting statistic that everyone really tends to overlook, in our country especially. There's been a progressively declining incidence of stroke over the past 30 years. The stroke risk now in the general population is somewhere less than 0.5% per year. Keep that number in mind, 0.5% per year. The CREST trial, which was considered one of the definitive studies to determine whether or not we should operate on carotid disease, and if we do, should we stent it or should we operate on with a carotid endarterectomy? The trial outcomes showed improved results from CEA and stent as well. Stroke and death rate for symptomatic was 4.7% and asymptomatic was 2.7% for CEA. And for carotid artery stenting, stroke and death for symptomatic was 6.4 and 4.5. There were some confusing factors or confabulating factors added into this database. One was the incidence of a non-Q-wave myocardial infarction, and there were the issues of cranial nerve injuries, most of which were marginal mandibular injuries, which all resolved and really did not cause patients a great deal of difficulty. And I consider those, they're fogging data to confuse the outcomes. There are some facts to consider. One is the screening risk, and this is very important because in light of the duplex talk you had this morning. In the United States, screening risk for stratified populations with carotid duplex imaging has been shown to show no benefit in terms of stroke prevention or stroke morbidity. There's no level 1 or level 2 evidence to support this, and consequently, I fully expect that CMS is going to deny payment for these studies in the United States if they're done as a screening study, even in a risk stratified population. Carotid artery stenting in the U.S. is reimbursed only if you participate in an FDA IDE trial or you're part of a post-market registry, and you must use a cerebral protection device if you want to be reimbursed for your effort. So the question is, what do you do with someone with an asymptomatic carotid stenosis? I think probably the best overall therapy is aggressive medical management. It's estimated one needs to do somewhere around 65 carotid endarterectomies without a complication or incident to prevent one stroke. So I think aggressive medical management, form of statins, antiplatelet agents, risk factor control, and comorbidity control is probably best. But what do you do with the patient who has asymptomatic disease that shows evidence of disease progression? And how do you judge this? Well, one way, they come back for follow-up for duplex imaging because they have known carotid disease. If they have vulnerable plaque by GSM, critical stenosis greater than 80%, their end diastolic spectral velocity, one that I use quite regularly, greater than 120 centimeters per second, and if they're at acceptable risk for intervention, or they've had the onset of new cerebral or retinal ischemic symptoms, then we consider them for either carotid endarterectomy or carotid stenting. I think it's important to realize that carotid endarterectomy and carotid artery stenting are not equivalent for stroke prevention, at least in the across-the-board practice in the United States. Carotid endarterectomy in asymptomatic patients of low or average risk, regardless of age, is a good thing to do. Perioperative procedural stroke and death risk is about 1.4%. Again, remember, the general population's stroke risk per year is less than 0.5%. Carotid artery stenting in asymptomatic patients considered high surgical risk or less than 70 years of age. Perioperative stroke and procedural risk somewhere around 2.5%. So who benefits from carotid endarterectomy? Well, I think all low and medium risk surgical patients, including those that are greater than 70 years of age, patients with acute cerebral or retinal symptoms who need intervention somewhere less than 7 days after the onset of symptoms, people who have adverse anatomy for carotid artery stenting, and there is a cost consideration when you look at carotid endarterectomy as compared to carotid artery stenting in our country. It is cheaper to do the endarterectomy than it is to do the stent procedure because of the cost of the devices used to do the stenting. Who benefits from carotid artery stenting? Patients at high risk for carotid endarterectomy. The class 3, class 4 congestive heart failure patient, people with a left ventricular ejection fraction, somewhere less than 30%, unstable angina, and recent myocardial infarctions, 6 months or more recent. The vascular issues would be a contralateral carotid occlusion. I personally don't consider that increasing the risk because I shunt everyone, patch everyone, but many people do not, and that does increase the risk if you don't. Recurrent stenosis after carotid endarterectomy, we just talked about that, and that is a difficult problem, and I think often best managed interventionally. Neck radiation, hostile anatomy, and a carotid bifurcation at or above C2. If you haven't been there surgically, that's a difficult place to get to, and it certainly increases the cranial nerve morbidity with the ones that really matter, the ones that interfere with swallowing. Thank you. I hope that helps a little bit in helping you decide what you'll do with an asymptomatic patient. Again, you're getting a conservative approach from a conservative surgeon. And I mentioned in the United States, 80% of the carotid endarterectomies that are done for asymptomatic people. That may change, though, with the new healthcare legislation. You may see reimbursement not come. Be happy to answer any questions.
Yes, we have 2 minutes for questions.
Can I? Sorry.
Sure.
I think, there was this presentation at the SPS just gone, last month with Mark Conrad from Mass
Right.
General. And he spoke about asymptomatic carotid stenosis and the meta-analysis which said that it was probably better to medically manage them rather than operate on them.
Right.
And then he went in and dissected this whole thing and said that if you divide them into 3 groups, which is the high severe ones, which is 90% and more, 60 to 79%, right. And that, these ones had a much higher incidence of progressive neurological events and progression, going up to almost 80% in 5 years. Right. They followed them up to 5 years. So his suggestion was that even though newer trials, if they were to be conducted, should have a medical management arm, but for now, asymptomatic carotid stenosis, if it is 70% and more, should be kept under kept under surveillance, and if they crossed, meaning that the progression was more, then you should go ahead even if there were no symptoms and intervene. And according to him, the surgical outcome, meaning endarterectomy results, were better than stenting. So any comments on that?
No, I agree completely. That's when I had a slide that I put in that it showed end diastolic velocity greater than 120, evidence of disease progression on serial duplex studies, onset of any symptoms, and I forget what the other one was. There are 3 or 4 entities, and if you have any of those things, then I think those are the people who, even though they're asymptomatic, ought to be intervened on. That's really the whole purpose of bringing back people and following them by either a cardiologist or their internist or by me, or a vascular surgeon or a vascular medicine person. The main reason for bringing them back and doing serial duplex studies
Check
is to see if they are progressing in their disease. Probably have, I'll bet, in a lifetime, I've probably done 3,000 carotid endarterectomies. I'm pretty old, I'm 77, okay? So I'd give it that. And of that number of carotid endarterectomies, I'm probably seeing in practice at any one time in a year more than 100 people with 70% carotid stenosis that haven't changed one bit in 5 years. They've been absolutely stable and have not had to do anything to them at all. But they're on good medical management. They take their statins, they take their aspirin, they do what they're supposed to do.
Thank you.